Assalamu alaikum. I think we'll start. Our first case is from IMC. I think it will be the operator will be Dr. Khalid Tamam and Dr. Lornell Dragwell, and the IVAS commentator is Stephen Carrier. So I welcome to the floor Dr. Alexander Avrian from France. He will be the facilitator for this. Dr. Alexander.
Perfect. So I think we start straightforward with the IMC Cat Lab. So Ralid, Dr. Tamam, do you hear me? So
Alex, do you hear us?
Perfect. So okay, so just to reassure you, there is more than 10 people in the room. Because he was scared yesterday.
Thank you.
So
you can take off.
Maybe you can present the case, and then we can discuss with the panel and all the room for the strategy, and maybe you can explain yours after. Okay?
Yes. So first, I would like to welcome all of you to our 7th edition IMC Live. I would like to introduce my co-operator, Dr. Laurence Dergour, coming from Nice, and Dr. Sharif Zaghloul, and all my team here, including Dr. Stéphane Crier, the IVAS commentator, Dr. Ahmed Zaatar with me also in the room, and my team, Chi, Ernie, Mahboub, Amira, and Kati, and all the team, and Hani, everybody is here from IMC. So I will let Dr. Sharif will present the case. So can we have a presentation slide, please? So can we, yes? Yes, please, Sharif.
Okay,
next one. No, next slide, please.
Yes.
Yes? Okay.
Okay, this is a 65 years old male patient. He morbidly obese with BMI of 44. He's hypertensive, hyperlipidemic, diabetes mellitus, and he have BPH. Okay, next. Regarding the patient investigation, he have been having chest pain for a long time, and his ECG saw T-wave inversion in anterior leads. His echo normal ejection fraction of 55%. And we did initially for him a CT coronary, which revealed a very high calcium score. So coronary angio was done for the patient, which revealed the CTO to the proximal LAD with retrograde flow from the right coronary. And the LCX, he had a proximal to maybe 70% lesion with some plaques. And his RCA has a distal 30 to 40% lesion. Okay.
Okay, so this patient has Euro score is low, and Centas score also is low. Next, please. And G scores for this patient is 2. Do you agree?
Yeah.
Ragul?
So good morning, everybody. It's a pleasure to work with this nice team, and my first time in this country. So thank you very, very much for inviting me to this nice congress. And as you can see, the Euro score is low, and the syntax score very low too. So okay for a CTO in this case, and maybe we have to wait to see the images of the angio.
I will show you the images. So can you have the image from beginning, please? Yeah, from beginning, yes. So we have we agreed to have our approach as a right radial 7 French, the cylinder sheath with 7 and 6 for left system. So here we inject the left system, we find a rupture plaque in circumflex. We agreed it was more significant in the diagnostic angio, and now it's a little bit regressing, but we decided to treat the circumflex before starting. And if you can see that it has a good retrograde as an antegrade also as well with a heavy calcified lesion in the LAD. So can you have next, please? Next, please.
Dr. Khalid.
Okay, you can see here the LAD. So LAD segment is the proximal cap is not appearing well, so it's ambiguous cap.
It will be the difficulty of this case,
yes,
and to have a good definition of the proximal cap.
Yeah, all the time the wire going to this branch maybe. Here circumflex is eccentric region.
So in this view, the marginal branch was not very significant, but as you can see, the next angio, we have a look at maybe a rupture of plaque in the circ, so we decide to treat it before the live.
Yes, and you see here in the spider view, it's, you can see the proximal LAD not clearly stamped at the bifurcation with these septals. Next, please. So we treat a proximal LAD, a proximal circumflex with a 4-0 promise stent. Next, please. Next, please. Next, please. Next, please. Next. 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 Next.
Ouais, d'accord. Mais j'ai 3 ordinateurs à gérer, donc.
Next. Next.
Ah ouais.
Next. So circumflex now is fixed. It's good. So we can work more easy in the LAD part. So I will let you discuss the strategy. We are here now, Alexander. So you start to discuss with the audience what's your strategy, and then we'll tell you what we'll do.
So I just asked for the first question for the audience and also the panel and moderator. In that case, for you, what will be the more difficult part? Is to find the proximal caps, to cross in this calcification, or to manage maybe the bifurcation with this diagonal?
Alexander, I think the more difficult part will be to cross the proximal cap.
Yeah, but it's not for you. My question is for the audience.
Ah, sorry. Sorry.
Can you have that? Yes, please. Take care of that.
Yes. Aran, to me, I don't think to find the proximal cap is not issue here, because from the spider view, we can see where is the cap. Okay. It's obvious to calcified CTO. I see the calcification on flora as well. And so, of course, penetration would be an issue here. And also, because of the civil calcification, crossing the CTO also could be issue. Regarding bifurcation, I think it will be okay. We can do either provisional or two-step regarding the importance of the side branch.
Yes, it's very, very interesting. Because why I ask this question? Because I think if you don't know where is the proximal cap, maybe your strategy might be different. If you know how to puncture antegradely, maybe the strategy might be different also.
Nice.
Do you have another idea?
Yeah, I agree with Omar, but with this one, I think there is a channel. So my approach will be antegrade first, then I'll try retrograde if not failed. Okay.
And I agree with Omar also, but in addition to that, even if we go with the antegrade dissection reentry, there is no significant diagonals near the distal cap, so it's promising.
Okay,
I
so
think we should remove the circumflex wires and re-engage. Okay.
Can we see a good retrograde filling so we can see how is the distal LED, mid LED, how many diagonals?
Yes, nice. You're in good position. Perfect.
yeah, maybe we will ask after to check the. I think it's a workhorse wire now. Huh? So, Ralid, maybe you can explain now what is your strategy and.
Yeah, I think this case is good for showing the wire escalations. So we start softly integrate by using these are also wires, as you said, is a sign blue, and then I change with filter XTR as starting. I negotiate with the wire, and if this one is not working, I will go with escalating with a Gaia second or Gaia third.
Okay, just
so
a question.
If it does not work.
The 7 French is for the right or for the left in your
for the
setup?
left.
For the left?
No, for the left.
Okay.
Yes.
But if we have a 7 French in the radial with slender, so if we go for retrograde, we will change for 7 French for retrograde. But we discussed that before, and we think maybe we have some change to cross antegrade. But we use 7 French in antegrade because in case of failure or antegrade, retrograde, we go for ADR in
yeah, and also if he has a lot of calcification, if we use rotablators, IVAS guiding, so we all can be used by 7 French. So
could you just show us again the spider view, please?
Yes, can you go spider, please? Okay. Spider? Before? No. I can give you another image with a spider.
Okay,
so go there to spider.
C'est quoi spider?
Yeah. Go to spider. Wait. Just a second, and I give you. I just put my wire and again show you the spider.
Go. I think we need to take time to have a good definition of the proximal cap because it's changed totally the strategy.
Yes.
And it's not important to spend long time to cross in antegrade and to, if it's not, it's ambiguous, and to go directly for retrograde.
No, don't move.
Okay.
So I think here you see it?
Yes, I see. So here the point is that we can say it's a blunt stump because there's no tapered part with this LED part. So we can see the calcification, so we can guess the course of the vessel. But in fact, who in the room take feeder XT family to start here? So maybe 5, 6, 7, 10 people. So we'll start with the Gaia family here. Same. We'll start with a stiffer one, like Confianza Pro 12 or Net 14. Nobody. So half of the room will not start because there is no answer.
Okay, give me a epicoden.
Alexander, I would try Conquest 12 as well. It's also a good choice to me in this case.
Yes, maybe.
Yeah. For penetration, sometimes we need that wire.
Go again.
Yeah, but Ralid make us a great demonstration of the feeder. Huh?
So it's a XTR, Alexander.
XTR, I
it's
like
not
this
the
wire,
XT,
you know.
Yes. I know you like this wire. In case of tortuosity with some calcification, this wire is very useful, and in my opinion, it is best than the XT, normal XT.
Actually, for antegrade, I am using always XTR for starting the wire. The tip control is excellent.
We go retrograde maybe, no?
So I think it's time to check retrograde. Yeah, okay.
Looks
so, which check here. Can you change the contrast? Okay, because I have a lot of air.
So at this point we cross probably the lesion, but we have to be sure that you are in the good position. So it's very important to do retrograde and
can we
to
have
confirm your position, because of course it's an XTR, but it can go outside, and I think we have some doubt about the position of the wire.
The point always we said that when we start, if the XTR is not looping,
Ouais, je t'entends.
it's mean you are
Voilà,
somewhere
c'est pas
good.
facile de
If
gérer la
you make a
network
loop,
parce qu'il y a pas de
it's
preview.
mean you are you can, because XTR is very difficult to have going subintimal without making a loop. So we check here.
Two options. Maybe it's a septal branch, or we are in good position.
Okay,
but
epicodal or
we are not
REO?
in the same plan as calcification.
REO cranial, yes. Okay, yes, this one is good.
Yeah.
Okay, yeah. So I think we are in diagonal. Yeah. Or septals? Yeah, septals.
Maybe it's septals, no?
Okay, so but we still can go somewhere. Huh?
I think the proximal cap is cross, but actually you have to go in the LAD, and maybe we will have some difficulty to cross this proximal cap because of calcification. So
I think here is much better.
yeah,
Yes.
Okay.
Khalid is doing a very good job.
Yeah. Yeah, I think we are in close, huh?
Very surprising about the position of the wire, because it seems to be very free to move with the heart, but what is your feeling?
Yeah, I'm feeling good, huh? So I think this here is can we have an epicranial, please? Epicranial? Yeah, straight epicranial. You know, it's very obese guy, so, and he has a lot of calcium.
Maybe calcium is outside the artery.
Yeah, outside the artery. So sometimes it's going. So I think we are good, huh? So what do you think, Alex?
I think everybody thinks that you are good, huh? But now you have to cross maybe the distal cap.
Yes, this I think these are.
So your microcatheter is Corsair, as I guess, no?
Yes, Corsair Pro.
Okay.
Which is it's good. I like it in the calcifications. So we will control here, and if it's good, I hope the Corsair. I don't think the Corsair Pro will yeah, we are good. Huh?
Perfect. So the first step is okay, but second step is to cross with the microcatheter in this calcification. So
yeah, you know what, Alex? If the microcatheter was not cross, but you see Corsair Pro,
yeah,
it's excellent one, excellent microcatheter, and I can rotate. So can you show me the? Yeah. So here's I can. If it's not this part is tough to cross, but if it's not crossing, I will dilate here with 1.0 balloon, and then I could go back and I put more stiff wires, more body wire to cross this calcification, because it will be difficult. So cannot pass. So I think it's not. I will not do much more here. So I will do trapping, and then I will go again with microcatheter to change with Grand Slam wires, because I need a good support wires.
okay. So let me ask to the audience some question. Then you can work a little bit to.
Okay.
So here we are sure now that the wire crossed the lesion. So the problem is that microcatheter doesn't cross. So what will be for you your next step? Using a balloon?
Yes.
Using extension of guiding extension? Or try another microcatheter? Or what will be your next step for you? Nobody wants to answer? Yes?
For safety.
sometimes you have a guide extension is good is a good example for crossing with the microcaster because they have a good support. This is a guiding caster extension like Gazelle,
yes,
for example. Sometimes if you have a small branch, you can put an anchoring balloon, which can help you to push more the microcaster easily, and you have a good support for the guiding.
Absolutely. So here we have the diagonal branch, as we can remember just before the proximal cap.
So show me the guiding, please.
So everyone will take a guiding extension here or an anchoring, or go with a small balloon?
Alexandra, we have a circ stand just we implanted and we have a wire there. We can put a balloon in the stand to anchor it as well. We can. I think I would do the first thing before extension.
Sure, because for economic issue, anchoring is cheaper than guiding extension.
Put Anju, please. Anju in the screen.
So here you trap the Corsair.
Yeah.
Yes.
Yeah, I trap the Corsair.
Okay.
No.
So what size of balloon you use?
I take other balloon. I take other balloon.
So one point is important is with Corsair Pro, it's better to be in 7 French. Because in 6 French with Corsair, you have some difficulty to do trapping.
Yeah,
with balloons.
The problem that if you not with Corsair Pro, with Corsair.
With Corsair, but
so
sometimes with Corsair Pro 2 in 6 French.
Okay. So give me another 1.0 balloon.
So now
1.25 or 1.0 sapphire balloon. So it's better always when you work with a fine cross or with a caravel, as Laurent said. You can use a cylinder with a 6 French. But if you decide to go with Corsair Pro, with Corsair, it's better if you decide to do a trapping, you should use a 7 French. Sapphire, yes. No,
So
1.25.
As you can see, we work with the Fielder XTR because it's not a dangerous wire. But if you cross with Gaia 3 or Net 14 or things like that, it's very important to change for workers wire.
Okay.
So
we have a question in
the distal part of the wire.
We have a question in the room.
Not in all of our cases, but in some cases, actually, when we use these wires, Fielder XC, it's not so dangerous as it's Conquest Pro. Sometimes I use small balloons to enlarge this type of calcification, then go with the microcatheter distally and change the wire. At this point, what is the choice of the operator? Will he use a balloon or will he?
A very small balloon.
A small balloon.
A small balloon, I think, to cross the. But you know, Fielder XTR is not a stiff wire, but it might be dangerous because when you look, you can see the distal part of the wire, and sometimes when he advances the balloon, the very taper part of the wire can make some perforation at the distal part.
Yes.
So it's not because it's not a stiff wire, then it's not dangerous.
Okay, Alex.
Yeah.
Is there a difference in the choice of balloon, 1 millimeter balloon, Minitrek, Sapphire, the Falcon? What is your choice?
My choice is Sapphire. Sapphire. 1.0 is, I think, one of the.
I think the only advantage of advancing a micro catheter downstream is just to exchange the tapered wire into a non-tapered wire.
Yes.
Otherwise, you are in the true lumen, as shown by the retrograde injection. And I think just advancing a small profile balloon would be sufficient in this case.
As you said, it's the only advantage, but it's a big advantage to switch for a workhouse wire, because then you are safe and you can manage your PCI as you want.
I think the other advantage would be to exchange for an
absolutely.
The shaft, I think, is not so supportive.
Or a rota wire if calcification are so.
Yes.
Is good for.
So here, explain what are you doing now?
So Lawrence will explain.
We have delayed with a very small balloon. It's
show me the guiding.
1.5 balloon and cross the distal part of the occlusion. And actually, because of security, we prefer to change our wire, so we reuse the microcatheter to change this wire. In my opinion, it's possible to work on this wire to do the angioplasty, but it's more secure to change from a normal wire. And so, as you can see, I need to do a trapping balloon. So we have the trapping balloon in place, we leave it, and we can go for the microcatheter with trapping balloon.
Yeah, it's very important this, because the plan, so they make predilatation, so the balloon cross, perfect. But then now they want to exchange a wire, so if they advance the microcatheter without the trapping, the feeder will advance also. So it's very important to use the trapping to remove the microcatheter, but also to advance the microcatheter again.
Down.
And then you can use
So
it
I
without
deflate the balloon.
angio, because microcatheter will stuck just before the trapping balloon.
So,
okay, down, please, show me the down.
So, as you can see, we move the microcatheter like a balloon, but normally you have to turn it counterclockwise to cross. But
give me a wire. Same blue wire?
In this case, it's okay. It crosses very easily after predilatation. So actually, we change for a normal wire.
Yeah, we take a same blue again. I feel I have a good feeling with balloon cross, so I don't need to have a stiff wire which can disturb my image, like Grand Slam wire. So I turn back to my same blue wires, so to be more economics.
And one point is very important, as you can device inside the guiding catheter. Trapping balloon, microcatheter, so we have to check the ACT every time because of risk of thrombus. So actually we must have ACT about 300.
Yeah,
okay?
now it's 400. Yeah, it was 400, so we give him a good heparin. So we take care of all this time. Can you have it back, please? Down. Okay. No, show me the guiding, please.
So you can see the balloon inside the guiding catheter, the trapping balloon. We remove the microcatheter in the proximal part, and we inflate the balloon to trap the wire. So it's a nice demonstration of trapping balloon.
Can I ask a question?
Yes.
Alex? Why not switching to a rotor wire and doing a rotoablation? This case is going so well, touch wood.
Good.
So why not to, the proximal part is a large vessel.
Yes.
Why we don't rotoablate well, so we really make proper preparation for the stent?
Yeah.
Yes.
So I think I will answer this question after checking the IVUS. So we check IVUS now.
So you're going to do IVUS.
Which see how is the calcium.
But I mean the length and the amount of calcium is so encouraging, I'll say, or inhibiting not to use.
We have a 2.0 balloon, 2.0 non-compliant balloon, 2.0 or 2.5. Give me 2.5 non-compliant balloon.
With rotoablation,
and then we'll decide.
Straight with the rotablation. Okay.
IVUS is a good idea to see, is it a superficial calcium?
2.5 non-compliant
or
sapphire.
It is very deep calcium.
Okay. But in the room, who will use actually in his lab IVUS here?
2.5 Maverick, Quantum Maverick.
So Roberto, I'm sure, is using IVUS every time.
Yeah.
But Manos also, IVUS. You will...
I mean, I think you can do IVUS and it's a good time, but the other option here is you cut the wire, the calcium is a lot, but you don't know if it's superficial or if it's deep. So another option here is to just take a 3.0 balloon, see if it expands. If it expands, you're done. If it doesn't, not. Even if you dissect, you can still rotablate afterwards.
Yeah, it will be also my choice to test the lesion with a non-compliant balloon and to see if there is a residual or not. If yes, Nicolas? Yeah.
Alexander, I think we could say now that the plaque itself is not that stiff. I think it's a soft plaque. And yes, there is a calcification certainly, but I think it's more advantageous rather than superficial.
Behind Nicolas?
It's okay?
It's okay.
I think the advantage of doing a rotablator is to better assess the side branch, because there is a one or two diagonal, and if you do a rotablator before balloon inflation, you will decrease the risk of dissection and losing one of a side branch, because I think we are in LAD and there is some diagonal, and by doing a rotablator you can better assess the whole side branch, because you will only do a debulking, and then you can decide if you have to protect side branch before inflation with large balloon.
Okay, it's a very good idea. So actually you are using non-compliant balloon?
Yes, non-compliant 2.5.
Okay.
Down.
Not yet on.
Okay. Okay.
The balloon is moving on the black, so.
Yeah, wait, just.
Yeah.
Okay. Down, down.
La 8 c'est on. Tu le vois?
It seems to have no residual at this part. But
No.
Down?
But maybe in the proximal
No, I need
cap.
Okay, go.
Yeah.
Down. Yeah. Down, down. Yeah, 16. Down. Okay, here. Okay, down.
I think if we don't have any a good opening of the balloon, do you think we need IVUS or?
No, I think
not?
always need IVUS. You know, we see a lot of calcium, so I think the IVUS will. Down. We can go even with a 3-0 again, with a 3-0 non-compliant balloon, and we can see.
Yes.
so here the proximal part seems to be more.
Yeah.
Okay, down. Yeah, okay. So I think we go with, we can prepare the rota here. Just prepare and stand by the rota. So we stand by the rotablator. So, yeah. Second.
So for rotablation, you have to change our wire.
Yeah, of course.
So we will reuse
we'll do IVUS.
the microcatheter.
We do IVUS. We do 3-0 balloon again to just, if it's not working, we stand by the rotablator. So can we have a here off? Okay. So blue towel, please, or green towel, please.
Green towel.
I think
I have to remove this one. Give me where.
what we were discussing,
Yes.
as we were talking about if we do the rotablation up front,
Yes.
You actually save contrast, you save radiation,
Yes.
you shorten the procedure, and you preserve the side
Give me green
branch.
towel. Huh?
So there's a lot of advantages, and then you can IVUS whenever you want, or you don't IVUS. It's up to you. It's your preference.
Absolutely.
But I think
Okay,
with this long
can you use
segment of
IVUS, please?
calcium, I think the first
Yeah.
upfront changing with the
Check the ACT from here.
microcatheter or whatever to a rota wire and go
Can
ahead
check
with
from
the
here.
rotablation.
That's flash good, huh?
So who is in the audience now will do rotablation now?
Alex, now since now we use the balloon as a test,
You
why
agree
we
for
need it?
rota?
My question, why we need an IVUS and rotablator? So if now I tested with the balloon and see it not inflated proximally, why not to go with the rota? My question, do we need
Yes,
an
but I
IVUS?
think we will ask the question to Ralid because I answered the same question. So Ralid, the question here in the room is why using IVUS now and not rotablator now?
So I just confirmed the calcifications by IVUS. Now sometimes you have eccentric calcifications which can be broken easy with the scoring balloon, non-compliant balloon, yeah. And sometimes when you use IVUS, you say, okay, this cannot be done with any balloon. So it's good demonstration to just
okay, so with the IVUS, you can decide if you are using rotablation or scoring balloon or a non-compliant balloon. Just to study the calcification.
Go back. Yeah. Wait. Forward.
Alexander, one thing is, I'm not seeing any more the diagonal that was at the proximal cap.
It's finished?
Yeah.
So I wonder if it's lost, if you put a wire there before you start doing more things so you don't lose it.
Yes.
Yes.
I don't know if you have listened to Manos' remarks about the proximal diagonal.
No, I don't hear. Can you, okay?
Because
we are concentrating in the IVUS, so just tell me.
Okay. So maybe can we have now the IVUS screen, please?
Can you switch to IVUS, please? So we have Alex Kipri with us now. Stéphane Crier, so he will comment in IVUS.
So Stéphane,
can you switch to IVUS, please?
Very happy to see you again. It's always a pleasure because for me it's one of the best IVUS commentator. And he's a very educational.
Can you put IVUS, please? I move you.
So we have not yet the IVUS screen.
Don't work. No, why IVUS is not working, huh? No, why is not working? So
because of some technical problem, you can see the.
Can you make a pullback, please, Stefan?
We can see.
Yes, and then we show them off camera. So
Stefan is going to comment the IVUS, maybe.
Pull back. Okay, just to move the IVUS guiding from inside, not to have a problem with thrombus. Calcifié. Just to not have a thrombus. I think so.
Okay, perfect. We can zoom maybe and then
rotablator.
So Stéphane, we listen to you.
Yep. Yeah, we'll take it.
For the moment, we can't hear Stéphane.
1.75.
1.75.
So maybe Roberto, you can be our IVUS commentator,
Yes.
no? Because we can see, you can hear us.
You do it again?
Yeah, I've seen that there's the most amount of calcium is in the proximal LED, as we have seen also with the balloon. In this case, I think it's very important to evaluate the MLD because you can have a good choice of the diameter of the burr on depend of the MLD by IVUS. I think that in this case, I think you need the 2.0 bar in order to have a real debulking, because otherwise, if you take a small bar, you have no real usefulness of rotablator in this case, because it's a very big LED and it's more than 3.5 in the proximal part, and I think you need a big size burr.
Yeah, it's very important to define MLD.
Otherwise, yeah, you cross with the burr, but you don't work because the vessel is bigger than.
Yes, the size of the vessel seems.
Very good point. I agree with you, Roberto. Yes. And also, there is a diagonal at the distal. I like to wire it before stamping or even doing another balloon to keep it open. There is
Yes,
a
but
diagonal.
the point is, if you plan to do rotablation,
no, I don't think so.
You don't.
After this, I'm not sure what works.
Okay.
So
Do you hear me?
Yes, now yes.
Okay, so from what I see from the plaque here, you have 90 to 180 degrees of superficial calcium, but on the other side, I see finally a lumen that is
down.
not severely calcified that you would need
Can you show me
rotablation.
the balloon is
And
little bit advanced.
we see that in the level of the most diseased segment, we have a 4 millimeter vessel, and but we don't see superficial calcium at this level. So I think that balloon would open, and you don't really need a rotablator at this level.
Are we
Then
distal
the
or
distal
proximal
part-
here?
So here we are
I think
in the distal cap. This is the distal part.
Yeah.
This is then more proximal. We saw some
down little
diagonal passing by.
Because this 150.
And more proximally, you see that we are a very eccentric plaque, some superficial calcium, but nothing very difficult to pass.
Okay. Down.
And more proximally,
170. Give us 3,000.
It's like a ring, huh?
at this level, that will still be
give me a rota wire?
3/4 of. But the iris could cross.
Yeah.
So
دكتور
that
ماشي
would be
كويس.
the aorta.
شريان فتح بس محتاج فتحته خلاص بس I need to
Very
rotate.
proximal
Make a
LED
rotablator
disease
because
from
of
the
calcium.
beginning.
Okay.
Okay, so what are your conclusion now of this IVUS, and what will be now your next step?
So I think as clear image that we should rotate because of the proximal ring shape of the calcium. So I think we have to rotate. I think Stefan, the 1.75 bar is okay for you.
Or 2.0 maybe.
Or
2.0 we have to use 8
2.0
French.
Yes.
No, we have to use 8 French. So with a
So
I
let's
think
go for-
I rotate only with 1.75 with a high speed.
With the launcher made from Mentronic, you can use 2.0 bar, I think.
Yeah, sometimes
in 7 French.
Yeah, Khalid,
So
Khalid,
it's-
Khalid,
yes.
Roberto speaking. Hello.
Yes, hi, Roberto.
Yeah, hi. Yeah, as Laurent said, you can do rotate with the 2.0 in the Medtronic 7 French because it's 206 millimeter, and so you can go in a straight way with 2.0. I think that 175 is really too small for this proximal LED.
So 2.0?
As you prefer.
Yes, 2.0, I think.
Okay. Okay, we use 2.0.
Khalid,
But
why
we
don't-
still have some technical problem with the rota. It need time to prepare, so you can go with any presentation you have or
Yes,
other
but
live
before-
until we finish
yes.
the
Yes.
rota.
Okay.
Finish the
We have just a comment from Omer.
Khalid, while you are
Yes.
waiting for the rota, why don't you try trio anti balloon in this part? In normal practice, in my daily life, I would do that, and after that, if the anti
Can you
balloon
please?
doesn't work, then I use, of course, rota.
Yeah, but already we start rota wire, so let's start with rota. I am agree with you. Give me epicranial. Epicranial, yeah. I am agree with you, Omar. Yeah.
Okay.
Usually
so
I do that.
One
what
more
you- as you
comment,
said.
and then we go for the first presentation. Okay.
Okay.
You said that the usefulness of IVUS would be to determine whether cutting balloon, for example, or rota.
Why don't
is
give me a
needed.
stiff one?
When you
No, this is soft one.
Depending
Give me-
on what.
No, it's not my comment. It's Rally Tamam
No, I
comment.
mean in this case, it's not a complete ring, the calcium.
I
Is it-
think I don't know.
Is it sufficient to use, for example, high pressure non-compliant balloon,
give a space.
or
Yes.
a cutting balloon rather than rota,
careful.
since it is not a complete? Or what is the cutoff? I mean, what is the cutoff range of calcium, which would determine what choice of
I think,
debulking procedure would
Yeah.
would be the of choice?
Okay, so maybe Roberto will answer. He's one of
I think that in this case it's very important to know the length of the calcium, because the calcium here is, the length is very short, it's a ring. I think that in this case, if you want to avoid rotablator, you can open with the non-compliant balloon or scoring balloon. I think you will open for sure.
And you have
with IVUS here, I think you can say that rotablator is not mandatory in this case, because the calcium is very short. Yeah, the segment is is a ring. Is a ring that is a big residual MLD diameter. So you need, if you want to rotate, you need at least 2.0.
Where is the gap?
But the segment is so short that normally you can open without rotablator in this case.
So can you just
the most of the occlusion is without calcium. Is a soft plate.
Roberto, I fully agree
take
with you.
two elements,
If we can
the
see back
circularity
the
and the length
wait,
of the
wait a minute.
calcium.
Yes, we.
No, 2.0 bar.
Okay. So
we don't
I
have
think
2.0.
we have to go for the
2.75.
first presentation. So.
Yes, it's going to first. 1.25, 1.5.
Yeah,
We
yeah.
will rupture the plaque.
Yeah, we'll just go to the first presentation until
We
the
don't have it,
rotablation.
1.27.
It is my pleasure to introduce Professor Masaki Okutsu to give us a very informative talk about utilization of CT and MRI for CTO. So very nice to have you back, and always will learn from you. Thank you.
Yeah, we don't have, wait.
Yeah, we'll just go to the first presentation and come back to you in the cat lab.
3.0.
If
Okay.
you can go ahead.
Wait, don't open the rota, because we have a technical problem with the rota. Yeah, well explained. Okay, we have some problem with the rota now,
good morning,
with technical problems.
ladies and gentlemen. Thank you
Okay, give me the
introduction
yes.
of me.
Okay, we are off.
Dr.
Wait a minute.
Hassan, and I appreciate to invite this conference. And my topic is cardiac CT. I'm sorry, not MRI. That's just only about CT. How to utilize this image to the CT or PCR procedure. Recently, we have many topics of the coronary intervention, and this conference is focused to the CTO, and then my topic is coronary CT. And usually the CT is used to check the lesion. Sometimes Agasson's talk, this is a screening of the coronary artery disease, and after that, we can find out the lesion, where is the lesion and how many lesions. And sometimes the physiology, but this is on developing. And then, but this information very useful to the treatment of the CTO lesion in the PCI procedure. This means that not check the lesion. This image is so useful for the guidance of the CTO PCI. What is the important point of the CT information for the CTO PCI? We introduce these 3 points. The first point is the entry and how morphology, the how shape, is very important to tourism intervention. Actually, this first case is also the entry point. The morphology is very important to in the beginning of the CTO PCI. The second is the root. This is, as you know, the occluded segment is not find out from the angiogram usually. So, but the third one is calcium distribution. This information is very important. First case is also calcified segment. Which calcium is very important. This is so useful to the treatment of the CTO PCI. First, this is the entry point of the topics. Now, as you can see, this is middle LED is CTO. At this point is no stamp. You can see maybe around here the entry point of CTO, but not so clear because of the no stamp and with many side branches. diagonal branch or septal branch. And CT image. You can see that this is the occluded segment of the LAD, and as you can see, very easy to find out the occluded entry point of the CTO. Of course, we usually use the IBUS to the side branch and checking the entry point of the CTO. This is very useful and very easy to check and find out the CTO entry. However, and of course, this case is very not so important of the CT data. However, there are like RCA CTOs, proximal CTO. The distal end is here, and this is easy. However, the entry points are where? I think that we can predict the two probabilities of the entry point, this point and this point. And then checking the CT. As you can see, that this is contrast staining the wide and the lumen. This is this point, and this severe stenosis is here, and the small branch is this one the same. And then the RCA main branch outlines, this is the outline. So the occluded segment is here. So we have to puncture this point to the CTO. This point is not the entry point of the CTO. So that is entry point find and identifying is a little bit difficult because IBUS cannot maybe advance to this small side branch. So the checking the entry point is a little bit difficult from the angiogram only. So I punctured this point, and then finally I used the retrograde approach, and finally, this is recanalized. The next case is a similar case on the entry point case. As you can see, this is the distal CTO of the RCA. The RCA distal part here, but the entry point is a little bit difficult. This point looks like a CTO entry. However, is it true or not? I'm not sure. So I checked in angiogram. This point looks like a CTO entry. However, this is a CT. The CT shows the RCA main vessel here. And this two small branch is a side branch. So this small branch is both side branch. So then checking here, and then this is the RCA main branch. So this means that this is the RCA branch, main branch. So CTO entry is here, not here. So this is a very important point to beginning the CTO procedure, because if you advance the guide wire from here, then maybe maybe of course no good. And then I approach this point and final retrograde approach and recanalize this CTO. Very easy to construct the CTO procedure. And then the lesson one, the CTO lesion without the stamp and no good side branch. Check the CT and the entry point will be identified very easy. And the next is the root information. This case, sometimes I will say CTO like this, relatively straight. However, sometimes have a tortuosity, but very difficult to identify from the angiogram only. And then if you check the CT, that CT visualize the occluded segment very clearly. And then the occluded root is like this. Very important information to advance in the guide wire, right? So the lesson 2 is a long CTO, and with, of course, the CTO lesion have a severe calcification. You can find out the CTO segment root. However, the no calcium or the few calcium CTO very difficult to check in the CTO occluded root. So the checking the CT and very easy visualize. The final topic is the calcium distribution. Now this is the LAD CTO, the proximal CTO. As you can see, the CTO segment have a heavy calcium. And actually the occluded segment maybe the 20 or 25 millimeter or something, not so long. But occluded segment have a severe calcification. And then This is a caudal view and the cranial view. As you can see, this is the entry point of the CTO, and as you can see the calcification of the occluded segment. And then check the CT. CT is also visualized the heavy calcium. This calcium is a good point, or good sign or the bad sign. Sometimes, usually not so good sign of the calcified segment of the CTO. However, sometimes good sign. This calcium is rich. I would like to check the cross-sectional image of the calcium. As you can see, this is the window level and the window width is different. This line is higher, below is higher, and upper line is lower, and window level and the window width. And then you can see this is a vessel outline, and this calcium is separated. And so the center of the vessel is the non-calcified segment. And the more distal part, it looks like completely occupied by the calcium. However, the change the window level and the window width, the higher, and as you can see a little bit dark area. This means that this center of the calcium have a non-calcified segment. And the more distal part looks like the C shape, and the more distal part also C shape. The center is a non-calcified segment, and the more distal part is it is separated, and the center is not separated, and the calcified segment. So this means that all segment is center of the vessel is not calcified. So this means wire can easily to go advanced if enter proximally this non-calcified segment, the calcium and the block to go out the guide wire go out of the vessel. This sign is sometimes the good sign and to advance the intimal tracking. This is like the peripheral calcium, peripheral circular type calcium. And then I checking the RA caudal view, and you can see the two layers of the calcium. And as you can see previously, the center of the vessel is not the calcified segment, so the wire enter this between the two layers, and the epicardial side and the myocardial side. The calcium and the wire is not so difficult to advance the more distal part. So this is a spider view. The spider view is a little bit different from the RA caudal view, and the calcium distributed a little bit opposite side, and the septal side, the lateral side, or septal side. So the guide wire should go advance like a little bit zigzag curve. So, and I advanced the guide wire, but this actually this wire is XTA is not so stiff wire, and this wire could advancing the more distal part between the calcification layer. So the finally achieved to the distal lumen, and then this is the final angiogram. This like this calcium is a very good sign for the CTO PCI. However, like this is another case. This is a LAD CTO. This is also LAD CTO case. As you can see, the entry point is not clear. This is no stamp and with side branch. So this CTO is not so difficult to check in the CTO segment. Maybe as you can see, this is here. You can see a little bit of calcification here, this point. So this point is should be, this is the calcium. So this point is entry of the CTO. Maybe it is not so difficult. However, this calcium is good sign or the bad sign. This is contralateral injection from RCA, and we can see the septal quadral channel. And this is lateral side. This is the main collateral feeding from the high lateral branch from here, this one. So, and then checking the CT. As you can see, the LAD, and These two diagonal branches here, like the small branch can visualize by CT very easily, and this is the third diagonal branch here, and this is the septal first main major septal branch here, and this is a small septal branch more this part here. So this is the LED main branch. The entry point is around here, and this is very easy to check it out from the CT information. And this calcification segment is a non-occluded segment, and actually this point is a very severe stenosis, and as you can see, that this segment is an occluded segment. So this is the CTO segment. Maybe that this point is the distal end of the CTO. So this segment is not so long, but calcified. What kind of the type of the calcium at this point? And I checked the cross-sectional view from the proximal side, and the proximal side, this is the diagonal branch, and the more distal part of the separated diagonal branch, and this is the LED main branch. As you can see, the calcium was distributed to the septal side, and non-calcified segment is lateral side, and the more distal part is the same. And then the more distal part, smaller the calcium. And this point is a very important point. Almost vessel was occupied by the calcium, and the distal parts are similar. And then the change in the window level, the window width. So, and a little bit dark area inside the calcium. This means the center of the calcium is non-calcified segment. Maybe this is point is connect to the distal to lumen. Now this I call this calcium the full moon type calcium. This calcium is very difficult to advance the guide wire. Actually, the antigrade, this wire is intimal tracking, and the retrograde is also. However, this point is very tough, and antigrade wire and the retrograde wire cannot pass the more proximal and the distal part. And then this point is finished. Sorry. This part, like this calcium is very difficult. So finally, checking the CT is very important and helpful to treatment the CT of PCI. Thank you very much.
I think for the sake of time, we'll just move to the next speaker.
Okay.
We'll leave at the end some time for questions. I would invite Dr. Gamra, who's from Tunis. Doctor is well known. Habib is a friend and a colleague and a regular participant of the Live IMC. He's going to talk about a very important thing that we see it every day and we have to keep it in our mind, which is radiation and contrast, which is very important. As we get carried away with the cases, we forget about how much radiation and how much contrast we have used. At the end of the case, we will be getting surprised, and the case is still going and they're still using contrast.
Thank you very much. Thank you, Mr. Chairman. Ladies and gentlemen, I would like first to thank the organizing committee, and particularly Dr. Khalid Tamam, for inviting me. It's great to be here. So my task today is to talk to you in the next 10 to 15 minutes about an issue, a very important issue, as mentioned by Dr. Kurdi, which is the risk of what we're doing. We're very passionate about what we're doing, particularly CTOs, and we forgot about the risk, not only for the patient, but for ourselves and for our personnel. As you know, we are nowadays treating on a daily basis more and more complex lesions, long calcified bifurcation, multivessel disease, and obviously CTO lesions. And these lesions are very time consuming and require more irradiation than simple lesions. Operators, and nurses and allied professionals present in the cath lab must be aware of the potential biological implication for their patients and for themselves. And this one of the lesions that we can have, the patient can have and we can have, as cataract, for example. And something that we should know is that among all the specialties that are facing this risk, cardiologists are the ones who are more facing that risk. And in this study, it's quite old, 2009, showed that cardiologists have the higher risk of radiation among the other specialties like anesthesiology, orthopedy, etc. The other thing that we should know is that there is a linear correlation between the risk of radiation for the operators and the patients. So we are, all of us, in the same boat. Operators, patient, but also nurses and allied professionals. And this is a very important issue, to a point that there is a very recent guidelines, an expert consensus document that was published by the American College of Cardiology with other societies on radiology, radionuclide, etc. And I suggest to you to read it because it is very rich and there is very important information for radiation protection and safety. Now, before we go into the details, I just would like to remind you about some basic concepts. I'm not a biophysician, so I really learned in the preparation of this talk, but there are some words that you might encounter and see if you read that document or other documents about this subject. Air kerma, for example, kerma stands for kinetic energy released in matter, represents the dose of radiation delivered to the air. And DAP or DAP, that's the dose area product, represents the dose of radiation delivered to the human tissue. Now, air kerma has been associated with what we call the deterministic effects of radiation, that is, the effects that are immediate and have a predictable dose response relationship with radiation, like skin injury, hair loss, lens abnormalities. DAP, however, also referred to as air kerma area products, is the products of air kerma and the extra radiation field area, is thought to correlate with the stochastic or probabilistic effects of radiation, that is the rare long-term effects that are dose dependent, but not threshold related. Examples of those effects are cancer, inheritable defects, and pregnancy complications. For instance, an adult coronary angiography would expose the patients to an average DAP in the range of 20 to 106 gray by square centimeter, and PCI procedure will expose the patient to 44 to 143. Now, how to lower radiation? There are many, many rules, many advice. I will go through many of them, and of course not all of them. Time would not allow. But one of the things that is really important is training, education. We should train ourselves and train our personnel how to do it. In some countries there is a diploma where you can get. You go to a meeting and then of course you learn about this and you get a certificate. Thank you very much. You have to plan the procedure. It's really important. If you have an obese patient, this is a risk case. If you have a complex PCI like a CTO, you have to have some techniques to reduce the radiation. And there are very simple things like positioning, for example, how to position yourself to the patient and to the table. One of these simple things is the patient should be placed away from the radiation source and close to the image intensifier. Just take an example. If the patient is 80 centimeters from the radiation source, 30 centimeters away from the image intensifier, the dose will be 1. If you decrease the distance between the radiation source and the patient, the dose will increase. And if you increase both distances, then the risk will be even almost 3 times higher. So we really, by simple measures, you can really reduce that risk. Another rule is to try to rotate angles to spread entrance skin dose across different sites. It's not advisable to have one single projection and you work for 2 hours in that projection. Radiation will be really very high. And of course, there are projections that are at higher risk, particularly LAU cranial is a high risk projection for skin exposure particularly. Now, other methods, you will have to decrease fluoro frame rate 4 to 7.5 frame per second instead of 15 or 30. That's what we have in the cath lab. This will lower the, the AP by 19%. Sorry. You have to decrease also the cine frame rate to the lowest, lower the magnification, and use collimation, minimize tolerance, and use fluoro save. You know, there is an option now in new cath labs, so you just save the fluoro, and then you can have an image that is saved, and not use fluoro instead. You have to be careful to keep the patient's extremities out of beam path, hidden risk, not reflected by air corona, particularly the extremities as shown in this photograph. And you have to be very careful in high-risk patients, particularly obese patients, diabetes mellitus, prior injury, prior chemotherapy, recent radiation exposure. Those patients, you have to be careful with them. Now, shielding for the operators, very important. I would not teach you anything about it. Just try to use it properly, because this will decrease by 63% the dose. If you use it again properly and not you know, just to have it in the cath lab. You have to place them the right way. Now, the operator position to the table is really important. Look, at just 25 centimeters difference between this position and this position will cut the dose by half. And this is even more striking in this slide. This is what had encouraged actually the development of robotic procedures. It's not very successful, it's very complex. But just to show that actually if you go away from the patient, you'll save a lot in terms of protection. Now, radial approach, you know that, it's high risk. There are trials that have used actually a pelvic lead shield. It protects more the operator, but expose the patient to high risk. So it's really subject of discussion. Now, the lens cataract risk is really a real risk. So if you don't wear glasses, it's time to do it, because the risk is at least 3 times than in controls. Now, nowadays we have very good X-ray systems that actually allow you with minimal dose a nice image. But just remember that sometimes you don't need actually perfect imaging. You can accept what we call noisy images, and like, for example, a coronary angiogram in a dilated cardiomyopathy, you don't need really very good images, because you can save a lot. Also, using the filtering can also improve the image without having to increase the number of frames. Like in this case, just filtering would prevent image saturation in low absorption areas. Collimation is something that it's very advisable. I got 10 minutes, but anyway, I have also a few slides about contrast, just to tell you that actually I will go to the conclusion and tell you something about contrast nephropathy, because before closing, just to tell you that actually there is a high risk. You have to be really careful, because the incidence is not that low. It can go up to 5%, and you have to calculate the maximum allowable contrast. There's a formula that is very well known, but you have to be very careful in identifying patients, risk factors for this, particularly the ones related to the patient, chronic kidney disease, renal transplant, older age more than 75, female sex, congestive heart failure, left ventricular impairment, volume depletion, nephrotoxic medications, anemia, and low serum albumin. There are also procedure-related factors, high contrast media, obviously, multiple procedures, lesion complexity, and hemodynamic instability. This is an algorithm to prevent contrast-induced nephropathy, particularly in patients with with abnormal renal function, you have to use IV hydration, and you must discuss with the nephrology team. Of course, during the procedure, you will have to avoid antegrade injection, particularly in CTO, use iso-osmolar contrast, use of hybrid techniques. IVUS can help you decrease the amount of contrast to be used. And you might consider the use what we call the renal guard system. I don't know if you know about it. This is the renal guard system. Actually, what is it? It's comprised of urinary collection, and there is a protocol actually where you will have to give some Lasix to the patient. But this device will allow to give the patient, to rehydrate the patient the same amount that was, lost by the patient. Finally, an interesting paper published this few months ago about zero contrast retrograde, in a retrograde chronic total occlusion procedure using IVUS. As you can see here, this is possible. So minimal or zero contrast PCI, when indicated, offers the opportunity to improve overall outcomes related to ischemic heart disease and prevent contrast nephropathy. So in conclusion, radiation safety is everyone's responsibility in the cath lab. Be radiation conscious during every procedure. Operator practices combined with newer technology can have a major impact on lowering radiation exposure and injury. Prevention of complications related to use of contrast represents a major component of a successful CTO intervention, and operator awareness, application of specific algorithm, and use of novel technology can minimize the risk of contrast-related nephropathy. Thank you very much.
On est OK pour le live, je sais pas si vous entendez. On peut repasser quand vous voulez.
Hello? Yes, okay. Perfect. Thank you very much for this great topics. I think we're going back to IMC cath lab. Ralid?
Yeah.
Okay, can you explain us what you did?
Okay, so we have some technical problems with the rotablator. We don't have enough sizes until now, so we believe we need to have a big size. So we go to plan 2 to have a non-compliant balloon, 3.0, and then scoring balloon. So we have a good, after discussion with Stefan and Dragul here, and we said that this calcium can be broke by 3.0 non-compliant balloon, then a scoring balloon. We was able to have a good result with a scoring balloon, and then we stent with a 3.5 promise element 38, and then another overlapping stent with a proximal part with a 4.0 18, and then non-compliant balloon with 4.0 after 20 atmosphere. Then this small post stent blacks was appear. Do check by IVUS. I think Stefan can mention the IVUS.
Can we see the IVUS?
You have to turn. Yeah, turn the IVUS, please. Turn to the camera, please. The IVUS, Stefan.
Okay, now it's connected.
That's okay.
So
that's working. Yeah. Okay.
We are here in the distal LED, where there is an healthy segment with minimal plaque. But if we move from here more proximally to the stent, you will see that there is a segment with a lot of disease that was measured, and at that level we were actually with less than 3 millimeters square of remaining lumen and more than 75% of plaque burden. So it was difficult to leave this segment just distal to the long stent, and we decided to put an additional stent at this level. You see the distal edge of the stent finishing in this large amount of plaque, which is calling for subacute thrombosis. More proximally in the stent, we see that the stent is well expanded. More proximally, we will see some eccentric expansion where the most important calcified segment was, but overall this is a very good result. We can have a look at this saved image going through the measurement of the distal LED that you see very, very healthy at this level, but the measurement more proximally in the stent, which was eccentric, but still 8.6 millimeters square, so much more than the distal reference of the LED. This is in the stent where we reach more than 10 millimeters square, and the proximal reference in the LED, we see that it is indeed a very large vessel that was media 5.2 millimeter. And distally, we see the disease segment that was later stented with the minimum lumen area at this level that was 2.4 millimeters square, and you see more than 70% of plaque burden that calls for an additional stent.
So we decide to put stent 3028 up to 16 atmosphere, and then we post standard rotations with a stent balloon up to 20 atmosphere, and here is the final result. So we are here now. This is the final result.
Yeah, perfect. Yeah.
So we thank you for being with us here. I hope you will enjoy the course.
According to IWOS, that part should be 3.5 according to IWOS. So
Yeah.
I would do more.
Yeah, but they post-delay it with 3.5.
40 up to 20 atmosphere.
No? You went to 20 with
No,
the
I'm talking about the distal stent, Khalid.
Distal stent, I put it to 20 atmosphere with 3.5. So I think it's good.
3.5, okay.
Acceptable result.
So perfect. Result is perfect. As we can see, you preserve all the collateral branch, as well as diagonal, as well as septal. So I think we can applaud you another time. Thank you very much, Khalid. Always hard to start the meeting like this. So then we will switch for a second live case from India. So I hope everything will well done. So hello.
We check the angel. We check down.
Do you hear us?
No, remove it upstairs, Manuel. No, we send him to CCU.
Okay, so we have a presentation of the center. Great team. Green one. Hello? Maybe I think they are live. So I think this is a case presentation. Okay, so I can make the presentation, but everyone can read. 49 years old, means cabbage, I think. Okay, next one. Okay, so I think it's RCA occlusion. Okay, next. Very beautiful collaterals from the septal. Okay, next. So the
CTO.
So
there is a proximal tight lesion with a significant mid-segment CTO. This is an ambiguous cap, with bifurcation of the RV branch and a long segment CTO, which qualifies it as approximately a JCTO score of 2. Next. Next. And so with that, I'm going to hand over to Dr. Surya Prakash, who is our mentor and leads the CTO.
Okay, good afternoon. First of all, my gratitude to Dr. Tamam and the IMC organizers for giving us this opportunity. And here it's a festival days here. In spite of that, all my team members and the staff assembled for the CTO live demonstration case here. First of all, my thanks to the patient who has got a patient to stay on the bed for almost 3 hours. And to my left, Dr. Kapardi, Dr. Vishwanath, Dr. Shah, Dr. Satyajit, Dr. Kapil, and Dr. Narayan Rao. And my right, Dr. Mr. Bharati and Lakshmi Narayana and Madhu and Prudvi and Padma, all staff, excellent coordination in the team. So this gentleman, as I said, I will start the case. As you know, this is a long segment ISR and ambiguous cap. And so we had a good retrograde collateral, which we have seen in the ariocaudal and the ariocranial view. One of the septal appears good. So my primary approach in this case, I preferred a retrograde. I want your opinion in this.
Okay, so I think first you may have a very huge cat lab because you have all these people behind you. I think it's incredible. Huh? So thank you so much being with us. So we saw the diagnostic angio, and so it's in-stent occlusion.
Yeah.
And does the stent is going close to the crux, or because we're not sure about that.
Yes, exactly.
Beyond bifurcation.
Just beyond the bifurcation.
Okay.
Just beyond the bifurcation. We lost the PLV in the ISR. It is retrogradely filling from the left system. The PD, just beyond the bifurcation, PD is filling.
Okay, so...
So what is the strategy? Can I know the strategy of chairpersons and discussants? How is approach, your approach?
So what is, your sitting was 7 French, I saw, femoral approach?
Yeah, 7 French.
Okay.
Actually here our intended strategy here is a retrograde primary approach with some anti-grade preparation. But right.
Okay, so you finished your case already. You're too fast with just the presentation. Okay, so he wants to go retrograde. So who here starts retrograde, or who is going starting antigrade here? Who is starting retrograde? Only 1 people, so everyone will go antigrade first, okay?
Because this is an instant CTO, we have to discuss the distal landing zone, because this is a bifurcation, and we have to assess by the angio if we have contrast inside the stent, because in that setting we can discuss an adequate approach. And also we have to discuss the way to try to reopen both branches, because there is a PDA
Absolutely.
and a posterolateral branch. And it could be very interesting to better discuss the strategy before beginning.
Because here the major risk is to lose the RV branch. Because then he crosses via septal, so he's in PDA, Then, wires going up inside the stent. But the risk is that when he will open, predilate this distal part, he will lose the RV branch. Is? Yes, I know, but I can't have
I could not enter the tissue.
Ah, okay.
We struggled quite a lot for 1 hour, not able to cross the tissue, very hard tissue there. So then the anti-gate wet preparation has been done. Corsair, you go to Corsair 135. With a Gaia 1 we preferred. And we want to do a reverse card, but one of the techniques I usually follow, if I feel in the instant restenosis, if I am the track, I quite often do a Rendezvous technique, which I tried in this case. But finally, a Gaia 3 could cross the antigrade. Almost we tried a Rendezvous technique, but we could not succeed. Then finally, with a selective injection, retrograde injection with the Corsair, next. So this injection showed we are in the true lumen. So I could cross with the Gaia 3 finally. But I don't want to keep the Gaia 3 there. So next, we had a balloon trap and exchanged and we have done a 1 millimeter sapphire balloon could not go, 1.25 could not go, Reservin, and finally Tazuna 1.25 who could cross and dilate the lesions. And serial balloons have been done with 2 millimeter, 2.5. And after that, we want to know the pathology. You give the injection of the Corsair injection. Show the Corsair injection before. Please show the Corsair injection. We are in the true lumen. This shows the true lumen. So once we are sure, we extended the wire to a Cyan wire. I don't want to keep the Gaia 3 at the distal because of the
So distally, there is some edge flaps are there, just distal to the stent. Then in the distal and mid segment of the CTO, yes, next. There is there's some dissection planes are also there which are tried through distal crossing. Here you can say hyper intense signals. Wire penetration in the mid segment of the ISR CTO. Then if you can come to the proximal segment, you can see the proximal segment. It is a heterogeneous tissue indicating a lot of lipid pools along with smooth muscle hyperplasia and neointimal channels also we can see. Some small micro channels will be seen, neointimal channels we can see. So this is a very interesting OCT findings of ISR CTO. If you can dig out the literature showing ISR CTO of OCT, you can see now the fine micro channels in the neointimal tissue with the heterogeneous lipid pools. So there are 3 types of pathological findings in ISR CTO by OCT. The one is neointimal hyperplasia, which is a uniform hyperintense signals, which is a smooth muscle proliferative tissue. Whereas second variety is a heterogeneous type of signal intensity, admixture of lipid pool signals as well as neointimal hyperplasia. So these are the things which was beautiful demonstrated in this present case on the OCT. Then the next steps will take care
Actually, the distal dissection on the OCT in the PD has been covered with a 2.5 stent. That's what we have done here. We covered with the 2.5 with the overlap with the proximal segment of the distal stent. And after that, the flow is established in the PDA. Next. Now our strategy is to do a drug-electric balloon, DEB. We got here a magic touch balloon, a sirolimus balloon, which we quite often use here. We got the distal stent is around 3. There are 3 stents here. The distal one is 3 into 37, a long time, 3 years back. Put this stent, so we are doing a DEB with a 3 into 40 balloon for the distal segment. What is your strategy in this ISR CTO? Really hard CTO,
Long.
no doubt.
Yes.
It took a lot of radiation for us and some contrast also.
Okay. So just one question. May we have a retrograde injection to see if there is a RV branch?
Yeah.
You want a RV branch?
Yeah, because
Retrograde injection.
it seems that you lose this branch, no?
No, this is
PLV
not
branch.
there from the
PLV
beginning.
branch.
This is not there from the beginning. We got only the PLV branch, which is filling retrogradely. If you want to, we can open it with a crusade catheter, but I don't feel which is filling retrogradely. So this one you can do. This is a 3 into 40 DAB. The nominal pressure of this is around 6, 8. You can go.
So finally, you
30
cross
seconds,
centigrade.
5.
Hello.
Any queries?
Hello. Cut off. Intermediate disruption is there.
Are you
Alex,
able to
would you-
hear?
Alexander?
Yes?
Would you ask them for the retrograde?
Please,
I think
please.
you are absolutely right. There is some staining on the PLV.
Yes.
We
There is
get
a
the
PLV
retrograde
exposed
injection.
in the ISR, but it is retrogradely filling from the left system.
Yeah.
So whether we should open it antigrade with a crusade is another step. We will discuss that.
Yeah. But
This balloon we have to inflate 2 times at 6 nominal and 30 seconds each time for the drug delivery of sirolimus.
But could you, in this timing, show us a retrograde, please? Retrograde injection
We'll
from the
deflate.
left.
We'll deflate the. Once it deflates, I will give the retrograde injection.
You can do RO
Show to
crane.
RO
You can do
crane.
RO crane. RO crane. No. No, you can. The disappearing of collateral connecting to the PDA and PLV is filling. You
So
can see
PLV is
beautifully. The
filling.
PLV is filling to epicardial collateral.
So you can see that you have a RV branch.
RV branch.
Yeah, maybe you have to go left cranial, then you can maybe.
Okay. Go to left cranial.
Allocrane.
Integrity. Yeah, retrograde. Once retrograde injection.
You can see PLV is filling.
PLV is filling.
You see, it's not a small branch.
We can do a open of the PLV, not a issue with the starts. So now we are doing the 3.5 balloon for the proximal part of the stent, which is the 3.5 stent. So we are doing for the ISR a DAB of 3.5 into 40.
Okay. So what will be in the room your strategy here? Huh?
PLV, they are asking.
For the PLV,
yes.
I
Yeah,
will
Alexander,
open
I think
with the
that
crusade
this case
catheter.
you need to open the posterolateral branch.
Absolutely.
Yes, yes.
So I think the dual
Yeah, yeah,
lumen microcatheter is I think is the good option. So you can do dual lumen in the PDA and go with the crossing the posterolateral branch.
Yes.
There is a small stem, maybe it's very short, and you can cross with a walk horse guard wire.
Okay.
I think from the very beginning, would you have approached it differently? I mean, we have excellent retrograde collaterals to the PDA. And what I would have done is invest some time going antigradely into the PLA. And that way, if we end up losing the PDA, we have 2 options, either get it antigradely with the dual lumen microcatheter or via those septal perforators. But losing the PLA at this stage with 2 layers of stents might prove to be challenging even with a dual lumen microcatheter, particularly with this very tortuous epicardial collateral going into the PLA. So perhaps securing it first antegrade would have been a safer option.
Yeah, the strategy.
Now it is retrogradely filling, so there is no acute issue for him.
You know, one question here is how much contrast and radiation have you used so far? Because I agree with you, you should get it. But if you use 7 gray, maybe it's not the best time to start on this.
Yes.
Visipac.
So
Dr. Rao, what's the radiation and contrast volume at this point? It would be interesting to know.
280 ml Visipac.
Contrast volume is around 280 ml of Visipac.
Very good.
Are you happy with that? You feel it is more for this long case and hybrid approach you had?
But so, what will be your strategy for the posterolateral branch?
I will do a dual lumen catheter and open the PLV. Not an issue.
Okay.
Maybe a plain balloon dilatation of the vessel will do first. So it is filling actually nicely from the other collateral from the left system. But even then, as you said, we have to open it. Okay.
Go on talking to.
So any echoes of this case, anything, any discussion for that?
But for the moment, the discussion is to use a dual lumen microcatheter to open the P branch, and then which wire you will use to cross.
Alexander, can we also learn the amount of radiation and the contrast?
He already told us 280 cc of contrast and radiation. I haven't understand, but it's not so high.
But here you used. What is it? No, it is not red pad. This is a scatter stomach. Scatter rad we are using. It's a bismuth antimony combination, and most of the CTO cases we use this,
which will protect from radiation.
Scatter radiation.
Scatter hormone.
Okay, so to protect the patient.
Yeah, for every CTO case we use this one.
Okay, so which double lumen microcatheter will you use now?
Okay. Go to
We are using Crusade only. Crusade we are using. Yeah.
Sasuke also available, but we, right in the lab we integrate here.
Okay.
Yeah.
So that's PD, and as you said, we'll go for the PLV also.
Okay, so because it's a very interesting position, you know.
We are happy with
now
the no collateral damage as a protocol. Retrograde injection. Right. So I check the retrograde collaterals and take out the systems there. So absolutely no damage to the collateral, and the left main is clean and systems are okay. So to be sure, no, go to the same view, Babu. I am pulling out the left system, which I think is unnecessary. The ACT is maintained above 300 and all the time. Okay. So we take a Crusade catheter. Time permits, we'll enter the LAO, please. Crusade with CN, maybe. Integrate.
And what would be your wire inside the Crusade to cross?
Already this is a CN.
Yeah,
this
but
is a CN is there.
the one you will use to cross for the posterolateral branch. What will be your guide wire?
I prefer a CN wire, I will see. go to the area Ukrainian, how much the length of the wire?
So what wire are you using here in the, yes? You have the mic?
No.
Here, yeah.
Bravo, doctor, great procedure. But
Hello,
my
Ukrainian,
question,
Lego.
he used only
Hello,
drug-eluting
Ukrainian.
balloon all through, or he put stents?
No, he put stents.
In the distal part, there
I
is
have
one
put one
stent where
stent.
he will decide to cross?
There's a dissection
or two
OCT, so I have put a stent there.
At the origin of the PL.
There is 2 layers now.
There's 2 layers now.
I think.
Confirm with him, please, this issue.
So what
Hey,
will
I
be
have three stents,
your choice for the wire to cross?
I would go for Quancus Pro, maybe.
So we will
For
go
the
for a
PLV?
soft wire.
Why stiff wire for crossing
nobody?
a side branch?
On a stiff wire? Nobody?
Why
So
I don't need
an
a
intermediate
stiff wire
wire?
for that.
So
take
do you
it.
think he
Yeah,
will succeed to cross? Yes.
Hopefully we'll do that.
Who
Yeah.
think he will succeed? A few, huh? So you are not optimistic, yeah?
Normally in this situation, I like start with the ultimate bros tree.
Yes.
This is a very good wire with the dual lumen crossing side branch. Is a intermediate stiffness, a good control, and I think that's much better than a stiffer wire that can go outside. Can cause perforation. And I think that very soft wire in this case they are not so useful because they prolapse. They cannot penetrate in the ostium of the postlateral branch.
Okay.
Another point is because the main branch is open with a stent, we can also use a microcatheter, conventional microcatheter, because sometimes the angulation with the double lumen can be difficult to manage to place the wire in a side branch.
Okay. So actually you are using a Scion wire, yes?
Yeah, soft wire.
Yes. I'll make a more bend in the wire.
A Scion.
Yeah.
Which one? Scion blue, Scion regular one, Scion black?
Regular only.
Regular one, okay.
Bend. Chin injection, I couldn't see. Small band area. This is anti-gravity. I'll give a Egyptian, see. Yeah, okay. Now we can. Still a lot of ISR is there. Whisper also is a good wire. I will try even whisper also. Give me whisper.
Alex.
Okay, 3.5 30 dilated. 3.5 dilated. After opening this one, I can.
So you modified the curve of the Scion, huh?
Tip I modified. Then if not, I will try to do with the whisper also. Yeah, okay, same. It will.
So I think Alex, the yeah.
Sylvain, tu m'entends? Ouais, je t'entends.
So Alex,
yes.
Yeah, I think we have a great learning.
Yes.
Case
Always.
here. I think First of all, this is a patient who had a previous stenting.
Yes.
So we have a previous angiogram.
Yes.
So we should have seen that previous angiogram.
Sure.
So we know really how the distal looks and what was the end result before, and so we know and we plan. So proper planning for the case is the key to success. And remember, my teacher always told me that. You have to have plan A, plan B, prepare the case well. And this is where we really has made maybe we have not seen the distal properly before we started putting another stent, where we made our life now more complicated. But this is a good learning case because we learn from these cases.
Yes.
And this is why we are presenting this. But even if you cross with the wire, it will be a challenge to cross with the balloon, a double stent layer.
It's a double laid.
Yeah, it's going to be very, very challenging to cross. And then you think of the long-term result as well. And you think of the left system is quite good. And I hope that it has a study before looked for ischemia. So we are doing this, all this, we're doing it for a good reason.
Yes, perfect. I absolutely agree with you, with your comment. Say we have a...
I think this is the main issue here. There is a double layers of the previous stent, and I think this is very difficult to pass this layer. What about the opinion that this branch or get a good flow from retrograde from the left system? Can we
That's
leave
what
it
I am
with
feeling.
retrograde flow?
It's a good retrograde flow is there.
Yeah, but I can ask you a
why to
question.
disturb that?
There was also a very good flow from retrograde to PDA first, so why to open the
PDA.
CTO?
Yeah. But I have to do this in the live to open the CTO, yes sir, important.
So how long did you try with this wire and switch for another
and I
one?
will try to whisper wire. Whisper.
Yeah.
You feel
regarding the
such
choice
type
of the wire,
two layers of length
regarding
to
the
cross
choice of the wire in
ideal
this
wire
case.
is ultimate
So he
cross
started
or
with a
filter
cyan.
XT?
Yes.
And the cyan, we know it is an untapered, the whole cyan family.
Yes.
So I think with an untapered wire, it is very difficult to cross two struts. First, the choice should be a tapered wire, like the XT or even a Gaia.
Okay.
Second, we should choose a hydrophilic tipped wire, like
This
the
is a
Whisper in this
hydrophilic
case,
wire. What I
or
took is a
the
Whisper.
Pilot family.
It's a hydrophilic.
And I'm not sure whether a polymeric coat would be useful, because I think
3.5
most of these
MC
have are softish at the end, and the polymer itself across these stents, I think the coat will be damaged with torqueability.
Okay.
So I mean, in this case, we need a trackable wire with good control.
Yes, but so you cross.
Filter XTR went. Yeah. Filter XTR.
Feeder XTR.
No, it is a whisper wire.
Whisper, sorry, whisper.
This is a
Hydrophilic
whisper.
coated.
This is a whisper wire?
It's feeder XT? No? Can you repeat the wire you took?
Whisper.
Whisper, okay.
Which is hydrophilic coated.
Can we have a retrograde injection to better assess the distal part?
Depend ఇంజెక్షన్ ఫస్ట్ కన్ఫర్మ్ ద పొజిషన్ చేద్దామండి ఫస్ట్ ఇది రానివ్వండి సార్ బయటికి అది అక్కడే ఉంటుంది ఏం కాదు మీరు ఇది ఓపెన్ చేయండి కోఆర్డినేషన్ ఇది తీయాలి కదా ఓకే ఇది అది ఓకే నౌ retrograde injection.
Yes, perfect.
Please retrograde. Retrograde will. This is retrograde, na? Sister, this is retrograde. This is retrograde. This go. Retrograde injection in which we want to give.
Same view. We can confirm.
Engage cheyali. Guiding engage. Hello, please. aspect. This is this. Okay.
Yeah.
ఇదేనా ఓకే ఏసీటీ చెక్ చేస్తున్నారు
Please check. Sin.
yes
Yeah, it is in that position.
is in the PLV.
Yeah, perfect.
So I will dilate with a 1.5 balloon and see the struts. ఇదేంటిది I will remove the crusade.
So now I will trap the crusade. So crusade is Fine Joe. I don't know what name you have in your countries. Crusade again? Or,
Crusade only.
Crusade.
Actually, we got a Sasuke also available with us.
Oh, sorry, yes. Yeah, but Sasuke is a new one from Azai, yeah?
New one from Azai.
Crusade is an old one.
Old one.
Kaneka.
Yeah, absolutely. So now it's in France, it's from Terumo.
Okay,
Okay.
పుష్ చేస్తూ తీయాలి
Now we are removing the crusade.
ఇది పుష్ చేస్తూ తీయాలి వైరు సెంటర్లో మీద పుష్ చేస్తూ ఓపెన్ చేయండి అది సెంటర్లో మీద పుష్ చేస్తూ తీయాలి అట్లా వచ్చేస్తుంది బెలూన్ డీప్లెట్ అలాగా పైకి రాగాలి క్రూసేడ్ డీప్లెట్ చేసి పైకి రావాలి ఓకే నో ఓపెన్ చేయండి బెలూన్ డీప్లీ ఇన్ఫ్లేట్ చేయాలి రావట్లేదండి
వైరస్
వైర్ వచ్చేస్తుంది కదా అంటే ఇన్ఫ్లేట్ చేసి ఉంచు
బస్ యా ఓకే
ఇదే కదా సెంట్రల్లో మీద రావాలి అంతేనా
అంతే యా మనకి
ఉండండి
మనకి ఇంకొంచెం
నిమిషం ఉండండి నేను ఇంకా రాలేదు
Now we remove the crusade. Now we are dilating the ostium of the PLB. Deflect. We deflect it. Yeah. Remove it.
ఈ వైరస్ విస్పర్ మీద ఇది అండి విస్పర్ వైర్ ఇది విస్పర్ వైర్ మీద టార్గెట్ పెట్టి అండ్ 3తో ఒక 3.5 బెలూన్తో మొత్తం స్టిచ్ చేద్దాం ఐఎస్ఆర్ చాలా ఉంది
Kissing, final kissing we can do. First dilate the PLB.
So now you plan to use a balloon?
Yeah, balloon dilatation for PLV ostium.
Which one?
PLA.
Okay.
Balloon. What is a balloon?
This one, balloon. For anything 1.25 take.
Tajuna. 1.5 mm balloon Tajuna. Yes, you can take.
Okay.
చేద్దాం 3.5 డక్తో చేసాం కదా మళ్ళీ
So everybody is confident about the crossing of the balloon 1.5 Tazuna?
So far we are optimistic for this tough case, so hopefully fine.
But for difficult lesions, tough lesions, Tajuna usually cross the this type of side branch ostium we have seen. So now we are confident.
ACT is 319. we're monitoring every afternoon.
Yeah. వెళ్ళింది కదా అబ్బా నిజంగా
Yes. Yes, we had difficulty.
No, first winning you have to white wine. White wine first you have to.
Idena?
White, yeah. No, you can buy. No, you can buy. Yeah.
No. As you said, it is tough. Going there. Take 1 millimeter.
What is the length of the balloon? Is it 15?
This is only 10,
10 mm. 10 mm? 10 mm. 10 mm length.
How long?
10 mm.
10?
10 millimeters.
10 millimeters length.
Okay.
We'll take a sapphire 1 millimeter.
So, if someone has some help to the operator here, the balloon is not crossing. Why? Maybe because wire get outside some strut.
No,
or he need more support, so maybe he can use PDA branch to anchor a balloon, and then maybe he has more support.
It's because of the alignment. The wire is going from the outer margin of the stent. That's why it has made an angle, and there are a couple of layers of stents. So that's why the balloon is difficult.
This is 1 into 10 mm.
But I don't want to try hard on this because the PLV is feeling quite retrograde and.
Now we are taking 1 mm into 10 mm, 1 into 10 mm balloon. No, it will difficult to cross.
It is a difficult work.
Yeah.
What do you feel? We should try hard for this?
Yes.
Which way?
So this is the same balloon?
No. This is sapphire 1 millimeter, lowest profile.
Okay, so sapphire 1 millimeter, okay.
Yeah.
1 millimeter.
Difficult to cross.
But just inflate the balloon little bit.
So be careful you're guiding.
Another technique we use. Then we'll push little keep off inflated 3-4 atmospheres. Then I'll push the balloon. Sometimes that will work out.
Difficult.
So it's a very hard calcific region, multiple layers of stents. I think if it is retrogradely filling, I'm happy with that.
So do you have another solution?
What about Alexander? What about going back to PDA and post dilate with a larger balloon?
They did already. They did before.
We have done it already. Now I'll give a final injection here.
Okay.
Injection.
Another thing, you can use 0.6 balloon.
3.5.
So
but Sapphire 1.0 is a good one already.
Good one.
Iris. But Iris will not help for the crossing.
Please. Too many studs are there.
There is two
Fill
things.
that above.
Post dilate,
You can perform a pot, a post dilatation just before the carina to open to open proximal.
I'm not much worried about the PLV, which is nicely filling from the retrograde.
To have a better push to try to
I will
cross
just settle the issue of ISR in the main this thing with a little high pressure dilatation with the higher size balloon. That's more important for me, I think. It's a PLV.
Dr.
I'm removing the
Iris would help here.
We have some suggestion from the room.
Please go ahead.
3.5.
You remove the wire, no?
Yes.
I removed. I'm
Okay.
interested.
So no suggestion from the
Because
room.
I know it's a three-layered stent there, and I may not achieve, and I don't want to spoil the main stent's ISR. That is more important for me.
Okay, perfect.
I think it is a protected PLV. It is a protected PLV like a bypass, protected LED like protected PLV. So better you have a good stent dilatation with the post-tency balloon 3.5 and having a good Dimitri flow to PDA.
Okay. Thank you so much.
Thank you. Finally, I sincere thanks to Dr. Tamam, and I dedicate this success of this case to my father, whom I lost recently. Dr. Tamam knows it. So, thank you all.
Okay, thank you so much for your kindness and all your team.
Thank you. Thank you.
Thank you. Thank you very much, Alex.
So maybe now we can have a break.
Yes. Okay.
Some
Thank
break. Break maybe 15 minutes, I think. 15 minutes break. You can have this.
On fait combien la pause? 30 minutes? 30 minutes? Margot, 30 minutes? C'était 30 minutes dans le programme, on reste là-dessus? C'est 30 minutes la pause, Alex. Ah, mais là, ils ont mis des chaînes au milieu aussi.
Break will be 30 minutes because you need a break.
Donc faut qu'ils sortent.
The exit point is from the other side. Exit will be this way. Exit is this way. Okay. No rules.
Il a redémarré le PC. Ouais. Et après, sur la transe, ça ne servait pas. Il y avait le son et le son.
Il est 21.
Je leur ai dit, mais.
Aux Indiens?
Non, c'est vrai. Cigarettes? No, a few cigarettes. 1, 2, 3, 4, 5, 10. So here you've got the satellite. So India is finished now. So we have no more. Yeah, but we have no more street.
Ça va et toi?
Internet connection. India is over. So
C'est-à-dire?
we have wireless and IMC and satellite.
Pour un iPhone. C'est quoi?
Should be more stable.
Si, attends. Tiens. Tu le laissais là ton téléphone? Ouais. C'est bon. Ouais, c'est bon, je te le garde ici. Non, c'est prévu. Alors attends, je te présente. C'est en haut. The presentation.